Professor Malik. When I was Googling about Professor Malik before coming to Bangladesh, and I found out that this is 1st December is his birthday, it became emotional for me. 1st December is the most important day in my life. And that is because the person who loved me the most, my grandfather, was also born on 1st December. And that was 1905 in Bannu near Peshawar. And so that is the day we celebrate, and in our family, we still cut the cake on 1st of December. And so that happens to be the most important day. And I just don't know why this had to be my first visit here, why it had to be on 1st December, and why it had to be Professor Malik's birthday as well, that I start my campaign as the president-elect from Bangladesh. My crusade will start here. And honestly, Professor Malik, I'm truly, truly grateful to you, because the campaign indeed started from Bangladesh. And Fazila, Ahsan, Aisha, Azam, I can't thank you all enough that it all started from here. And I don't think I would have been here if there was not a support from them. And I think if we start here from Bangladesh, and I've talked to Hafiz multiple times about this, that I would like to see whether we can present this place as the model place for the low and middle income countries. I've always been fascinated by Bangladesh. High intellectual content, maximum level of disease, density of the population, which is maximum density of the hospitals, maximum density of the cardiologists here. I think this is the place where we can really make a difference when you are calculating for any study the sample size, and then you see the endpoint, and you figure out what is going to be the size of the impact, and then you calculate the sample size. I think Bangladesh happens to be the one which fits the bill the most. So I pledge here that we will start, as I start my term in 2023 on January 1st, I think NHF will be the place where we will start and spread. So thank you very much.
Thank you. Thank you once again, sir. Now I would like to request our today's chairperson, National Professor Brigadier Richard Abdul Malik, founder and president, National Heart Foundation of Bangladesh, to deliver his speech.
Bismillahirrahmanirrahim. Dr. Jagat Narula, Professor Khandokar, distinguished faculties from home and abroad, faculties, delegates and participants, ladies and gentlemen, Assalamu alaikum. I am really happy today that Vice President of World Heart Federation, President-elect 2023, and many distinguished faculties from abroad has come at our invitation. Thank you very much for coming over here and making our event a success. Thank you very much. Because of my age, I could not be here in every time with you, but please forgive me. My other people will attend you. Thank you very much for coming over here. Now, Professor R.K. Khandokar has told you about our motto and what we are doing here. You will see our activities. Now, cardiovascular disease and NCD is a global problem. But Bangladesh is not an exception, and it is emerging as a serious health problem. But for government alone cannot do, so non-governmental organization like Heart Foundation is playing a vital role for prevention and control of cardiovascular disease in this region. We are working here at a tertiary level and also working in the grassroots level. And tomorrow, not tomorrow, I think on 3rd, you will visit community clinic and everything. You will see how they are acting, as Professor Khandekar has told you. But we believe prevention and research work, nobody pays for anything. But in this country or developing countries, you will have to treat the patient, then they will come to you and they will listen to you. Because if you go on telling them prevention, they will not listen. Because ignorance is a big thing. So we have got plenty of problem, but there is a resource constraint. And that resource is in the form of, in terms of manpower and also in terms of money and everything. The facility is not. And our people are totally ignorant. Many things they do not know. So we'll have to work very hard. Working in developed country and working in developing countries is quite different. Because we got training there and we know American highway code, but we cannot drive in this busy road. So we'll have to do innovative ideas. So thank you very much. You will see our things. Thank you very much. So here, as a part of continuing medical education, every year they hold a conference and international giants come here. So I will advise our young doctors and that you should try to pick up from them. They have come to tell you, to teach you, so you learn from them because nobody can feed you here. So try to avail this opportunity. They have come over here to teach you, to give you something. Thank you very much, all of you, for coming over. Please remember, overnight, you cannot be accepted like Jagat Narola. It takes years to develop this. A mission out of factory, it is okay. You can give full production, but a human being, it years. So whatever for success and failure in your life depends on you. You must work hard, believe in God, or whatever things. But if you work sincerely, you will get the result. So thank you very much. And I again thank Professor Narula, Dr. Narula, and others who have come over here. Thank you very much. I wish our country will advance, and our government is our Prime Minister is our chief patron, so we get always help from them. Thank you very much for coming over here. I again thank all of you.
Thank you. Thank you very much, sir, for the most valuable speech. May I now request Dr. Tawfiq Sharir Haq, Associate Professor Cardiology, National Heart Foundation Hospital and Research Institute, for the vote of thanks.
Honorable Chairperson of today's program, Founder and President of National Heart Foundation of Bangladesh, Brigadier Abdul Malik sir, our guest of honor, Professor Jagat Narula, Vice President and President-elect of World Heart Federation 2023, Professor Khandekar Abdullah Al Rizvi sir, and Professor Fazila Malik madam, and the August gathering. It's my pleasure and privilege to thank you all for joining today's program. First of all, I would like to thank the participants, the delegates, who has been the true inspiration for us to arrange this program every year, and they always inspire to thrive better the next year. I would like to thank the faculties who has taken the time out from their very busy schedule and traveled from different parts of the world to share their wisdom with us. I would like to thank the organizers, every staff, every doctor, every consultant of this hospital who has worked hard for the last 2 months to put up this show for all of us. I would like to thank the sponsors who also encouraged us and has been with us with ideas and many other things so that we can make this program very successful. And lastly, I would like to apologize for any flaw that may be present in our program. It is our fault, but I would like to request all of you to excuse us for that and enjoy the program. Please participate, interact, and make this event a memorable one. Thank you very much.
Thank you, sir. Ladies and gentlemen, now it's again a special moment to celebrate. It's a time for unwrapping the book cover of NHF algorithm for managing cardiac patients. So I'm requesting our chairperson, guest of honor, and all other respected person, please unwrap the book cover of managing cardiac algorithm. And the last consecutive years, we have also a manual on cardiology, manual on ECG, manual on intervention, and the emergency book. So this year we have this. So congratulations, and please give a big hand to the publisher and who worked relentlessly and so effortlessly to make this happen.
I would like Ishraq and Kaleem to come on the stage as well. These guys worked overnight. They were phenomenal. So every year we try to do a manual. This year it's very simple. It's just for our junior doctors so that they can sort of follow the algorithms. So it's NHF algorithms for cardiovascular problems.
Please, all of you come together and let's have a picture. So this is our NHF algorithm for managing cardiac patients. Thank you. Thank you all, ladies and gentlemen. With this vote of thanks and unwrapping a book cover, we are concluding our inaugural session. And with due permission, let's begin our scientific session. Our first scientific session is on dealing with complex and high-risk interventions. And to chair the person, I would like to request Professor Keith G. Oldroyd and Professor Nazir Ahmed. The discussants of the sessions are Professor Chung Won Go, Professor Abdul Wadud Chaudhry, Dr. Tom Johnson, and Dr. Kamal Pasha. We have eminent speakers for this session. So may I now request honorable chairpersons and discussants, please do come on the stage and grace the chair. And our other sessions are simultaneously ongoing in Hall B and Hall C.
So there's a training village which will start.
Yes, there is a training village. So you can join there. It will start at 11. Today is our chairperson, Professor Keith J. Oldroyd, Clinical Director of Cardiology, Golden Jubilee National Hospital, Glasgow, and Professor Nazir Ahmed, Professor of Cardiology, National Heart Foundation Hospital and Research Institute. May I now request our discussants, Professor Chung Won Go, Yuva University, Seoul, Korea, Professor Abdul Wadud Chaudhry, Professor of Cardiology, Dhaka Medical College, and Dr. Kamal Pasha, Senior Consultant, Square Hospital. Ladies and gentlemen, please be seated. Our scientific session is going to start. So please be seated and enjoy the session on dealing with complex and high-risk interventions. We have a number of eminent speakers for this session. So let's enjoy.
Hi, शुरू करबो शुरू করে দেব শুরু করে দেব
Chairperson, I would like to request to invite our speakers.
Thank you everybody. Welcome you today's session. This is the first session of first day, and the session is dealing with complex and high risk interventions. And there are five speakers here. First of all, I like to invite Professor Fazilatun Malik for his drug-eluting stent and drug-eluting balloon, gaining insight in latest dual technology. Dr. Fazilatun Malik is the Chief Consultant Cardiologist and Director Academic Affairs in this hospital. I like to invite you.
So, friends and colleagues, it's indeed an honor and privilege for me to be here. And today I'll be talking about drug-eluting stent and DEP technology. So, you all will agree that when we are doing a PCI, the most common comorbidity that we find in our patients is diabetes. And indeed, in a high volume single center registry, they found that in fact, in around 46.9% of the patients that undertook PCI in that center were diabetic. And in our country, actually, in our center, the picture is even worse, it's higher. And let's face it, when a patient has diabetes, it obviously increases the risk of cardiovascular events and death for that patient. And why is that? Because patients with diabetes mellitus tend to have a very high atherosclerotic load. They have increased necrotic core volume, increased inflammatory infiltrate, and increased calcification. And these plaques are usually very diffuse. The vessels tend to be narrow caliber. So when we treat these patients with a drug-eluting stent, the results might not be that great. Why? Because obviously there's delayed vessel healing due to the slow endothelization and increased inflammatory response. And this translates to an increased risk of acute, subacute, or even late stent thrombosis. And instant restenosis can also occur, which can be diffuse in nature, focal, or because of the high pressure balloon inflation we did, it can injure the edges and lead to focal or peristent instant restenosis. And the fact of the matter is that regardless of what type of stent you're using, a diabetic patient will have relatively poorer outcomes than a non-diabetic patient when that patient undergoes PCI. So here there's a rather innovative technology that the luminous DES Plus system has come up with, which seems to be helpful for diabetic patients. Now, what are those new innovations that would be helpful for a diabetic patient? Well, first of all, there's fusion coating. So there's coating on the stent as well as the exposed parts of the balloon. So this facilitates homogeneous drug delivery, and so it hopefully will address diffuse proliferative disease in diabetes as well as the focal restenosis at the edges of the stent. There is edge coating. So the edges of the exposed part of the balloon is coated with drug. And so the additional 0.5 millimeter of coating on the edge of the balloon, and this addresses the issue of edge restenosis. The biodegradable film allows homogeneous drug delivery, and its abdominal coating. The abdominal coating on the stent facilitates monodirectional drug, and this leads to faster re-endothelization. And this is a true thin strut stent. And yesterday also we were talking about whether thin strut strength translates to greater safety, and studies have indeed proved that to be so. And in this case, 50% of the drug is released in the first 7 days, and 70% of the drug is released in the 48 days, which facilitates for fast and effective endothelization. Another important fact is that in many drug-eluting stents, the balloon is crimped after it has been coated. And with that, you might lose some drug while it has been crimped. But here, it is first pre-crimped and then the drug is put on it and coated, so the chances of injury are less. And so this unique combination of a drug-coated stent with a drug-coated balloon may be an answer to effectively treating patients with diabetes mellitus and who are undergoing PCI. And in fact, this abluminous DES has already received a CE mark for treatment of diabetic patients. So I would just like to illustrate this with a case. This is a 60-year-old male patient. He was a migrant worker, and we actually have a lot of people who work from Bangladeshi people who work in the Middle East. And so when they get sick, having a bypass is not an option for them. Why? Because they want to have their treatment quickly and join their jobs because it's their livelihood. So he was also a migrant worker. He was having chest pain. So he came to Bangladesh. He wanted his treatment quickly so that he could go back. And he's obviously diabetic with ejection fraction of 53. And this is how his vessel looks. You can see that there is highly calcified, long diffuse stenosis in the proximal and mid segment of the LAD. The diagonal is also very severely diseased. The LCX is a non-dominant vessel, diffusely diseased, and the RCA is dominant and free of any significant disease. Now, wiring the LAD proved to be a bit of a challenge because there was this huge chunk of calcium sitting in the proximal part of the LAD. We attempted it first with a run-through, but eventually we were successful with a pilot 50 and a support of a fine cross microcatheter. Our wire actually went into the septal, but with gentle negotiation, we were able to pass it down. We exchanged our pilot wire with the help of a fine cross for rota wire. Because here we knew upfront that rotablation would be required. This is a heavily calcified vessel, and studies have shown that you should use rota early on rather than try to do it after you've attempted with other devices. So here we took upfront rotablation with a 1.5 burr. And at that point of time, we were able to take our IVUS in, and we saw that there was huge amount of calcium, almost 270 degrees of superficial calcium, in some places almost 360 degrees. At this point, we wired the diagonal with a floppy wire, this also with the support of a fine cross microcatheter. We did pre-dilatation of the LAD with a 2.5 by 20 NC balloon. The IVUS had shown that this really needs a lot of work. And for the diagonal, we did a very gentle pre-dilatation with only a 1.5 by 15 millimeter NC balloon. We didn't want any major dissections at this point. We did further pre-dilatation with scoring balloons, and then we covered the mid segment of the LAD with a 2.5 by 32 abluminous DES plus. We deployed it, and here one thing you need to remember, for the drug to be eluted from the edges of the balloon as well as from the stent, you have to keep the stent inflated for 45 seconds at least. If your patient cannot tolerate 45 seconds of ischemia, then do 30 seconds consecutives. Like if you are implanting the stent in the left main, your patient might not tolerate 45 seconds of inflation, but to elute the drug properly from the stent and the balloon, it has to be a prolonged inflation. After that, we again took a second abluminous DES from the ostia to the proximal part of the LAD, and we deployed that as well, keeping it for 45 seconds. We then rewired the diagonal with another floppy wire with the support of a microcatheter, removed our jailed wire. We did NC scoring balloon, 2.5 by 15 NC scoring balloon for pre-dilatation. And then we took a Magic Touch drug-coated balloon, a 2.5 by 30, and we kept it inflated for 60 seconds. Now here there's a bit of dilemma also. Some people prefer to use the drug-coated balloon prior to the stenting, because the theory is that you might strip the drug from the balloon while you are negotiating it, but it went very easily for us. We then did final kissing with a 3x8 NC balloon for diagonal, for LAD, and 2.5x8 for diagonal. After that, we again took a IVUS catheter, and we found that our area now was adequate and the stent was indeed properly apposed. There was no malapposition, and angiographically, this was the final result. So in conclusion, we would like to say that this is indeed a new technology that might help our diabetic patients with this combination of drug-coated balloon with drug-coated stent. With that, I would like to conclude my presentation. Thank you.
Thank you, Professor Fazilatunisa Malik. And next,
No, so we will be having questions and answers, and then
later on.
you
or
wanted
now?
to. Is the discussion later on, or is
The
it?
discussion is on later part, after finishing all the lectures.
Okay, right. Thank you.
Next speaker, Professor Chaudhary H. Hassan from USA. He is very popular in our country also.
Good morning, everyone. I'm going to present some cases and share some thoughts, and let's see whether we can come to some kind of consensus on this particular issue about how to do viability assessment and where are we now in terms of utilizing the viability testing, and then think about the issue of revascularization. I must tell you this, coming to National Heart Foundation is like coming home, but with little bit of fear. The fear is that this session is like playing T20 cricket because the timer is on. So those who give talks here, they know the feeling. So bear with me. So 2007, we published this case with Morton Kern. So patient had a LAD occlusion, collateralized flow, ostial LAD, ostial left main, and we're thinking, should we do this surgery, or should we do some kind of viability testing and keep the revascularization strategy minimum? So we did the MRI, we saw the gadolinium enhancement, whole LAD territory is enhanced. So we thought just take care of the ostial left main and call it a day. Unfortunately, we don't have a follow-up EF, but short-term, 30 days, patient did well. So how we utilize this information? We know historically those with the multivessel disease, bad EF, and I don't know, we have any surgeons here. EF bad, coronary artery bypass surgery, look at the odds ratio, and then it's favorable, but if it's too bad, the surgeons do not talk to you. So you need to be just there, compensated, hemodynamics okay, not in shock, all this. And it has a cost. The cost of the surgery, as you heard from Professor Fazila Malik, that nobody likes cabbage. Cabbage has different type of implications in different parts of the world. And cost is maybe cheaper here, but cost is much higher in the United States. So we said, okay, let's do some viability testing and see. It makes sense. You rob the bank if there is money. So you look at these scenarios, and this is like a myocardial perfusion scan. So the fellows, the myocardium basically uses the fatty acid when there is ischemic myocardium in the face of chronic hypoperfusion. The heart doesn't move. We call that hibernating myocardium, and the metabolism switches to glucose, and you give the glucose tag with the FDG, and you lights up. you say that there is viability. Okay? But the bigger question is, what does it mean that the viability is there? Will that mean that it will translate into better myocardial contractility? That's a different story, but let's bear with this for now, that our goal should be to improve LV function and probably, even more importantly, to alleviate symptoms. Symptoms, probably ischemic symptoms, not the pump failure symptoms. And I'll come to that in a second. And then translate that into overall what we all like to see in cardiology is the survival benefit. But the term is disturbing, ischemic cardiomyopathy. What do you mean by ischemic cardiomyopathy? Is it scar cardiomyopathy? Or is it Cabbage-related cardiomyopathy, previous MI-related bad EF cardiomyopathy? Or should we define it better? Because in many ischemic cardiomyopathy, there is not much ischemia left. In some patients, there is only scar cardiomyopathy, but patient has Cabbage before. And what is the cardiac mechanics? LV is remodeling. And Dr. Narula is here. It is just remodeling and ongoing signal change and apoptosis happening. And is there anything that we can do to reverse remodel? A lot of questions. Why I'm bringing this up? I'll tell you in a second, because our current trials tell us and give us a lot of insights. Those who are in fellowship, you know that the viability testing does challenge this cell membrane integrity, cell metabolism, and then you do this rest redistribution thallium, a lot of fallacies, sensitivity issues, and specificity issues. And there is even more, and Dr. Narula is one of the champion of that, is the combining multiple modalities of viability. But I would tell you what I would like to see, that some viability that gives us a clue that there is increased there is a predictable contractile reserve that will translate into better EF. So if you look at this we are seeing, and Dr. Narula did a editorial, seeing dead in life, that you look at this and gadolinium enhancement, and do you see the infarct, the death while the patient is alive? So that is the background. Then let me quickly go through the patients. 62-year-old, this EKG, and look at this, a lot of precordial Q wave or poor R progression, poor man's way of looking at viability. LV is bad, pleural effusion. Farooq Bhai is not here. Surgeons generally do not like to see this, and they throw towels, find excuses, and then do whatever you want to do. So, and then this EF, and then these targets. So what to do? So we thought, okay, then we'll just go ahead and do viability scanning. Very encouraging results, a lot of lights up in the myocardium. And then we said, okay, Protect 4 is not out yet, right, Damesh? Protect 4 is not out yet. But we bring this, okay, maybe good. A lot of encouragement, but disappointing that we did an analysis and published just in AHA in the abstract form in the 17,000 database practical real world analysis, and Impella, no benefit. But we'll be waiting for the randomized trial Protect 4. Anyway, we did this Impella supported high risk PCI. We got this and it is better. We thought we did a good job. We don't know the long term, but another patient, 61-year-old with this EKG, and then bad EF everywhere, but there is LV aneurysm. For the sake of time, I'm rushing, and this right coronary, and then this left system ostial circ LAD, and then we ask ourselves what we should do. So syntax close to 33, and then this viability scan. What do we do? High risk PCI, Cabbage referral, high risk PCI only with ventricular support with Impella medical management. So this fast forward, what we have learned from the stitch, now the stitch follow-up, All these may be viabilities, guided revascularization better, may not be. And then a lot of twists and turns. And then finally, the Revive 2, well designed, much more tedious work, viability guided. And in Barcelona, we saw this pin drop silence in the room when the Kaplan-Meier curve was superimposed 0. No improvement in terms of survival. Whatever way you tease out, EF did not get better, maybe some symptoms improvement. So my question is, what we have learned? What we have learned from the viability guided, and this is the whole study, and I congratulate them because how they did it. And then look at this, superimposed and no benefit in terms of that. So where are we now? What we should do for our patient? This is the conclusion they did. And Dr. Pereira basically said, this is it. Dr. Pereira basically said, this is it. My question is, what went wrong? And bring all this information for our patient. Should we go for complete revascularization? And was there any problem that they did not do complete revascularization? No, they did as much as they could. Does it make a difference? Should we do cabbage so we forget about what's happening upstream, further events? How we can look at the myocardial mechanics and tease out some patients where there is more money, more potential? But a lot of questions remain to be answered. For our patients, what do you think we did? Guess. We did nothing. I restrained myself. I said, we are going to give you guidelines-directed therapy, maximum 4 pathway-based survival benefit drugs. You know that what we are using now. Revisit by time, follow up, and then we'll think about, maybe we'll do a ischemia testing and then decide. But we'll discuss more on that in the question and answer session. Thank you.
Thank you very much, Professor Ahsan. Next speaker is Professor Mir Jamaluddin. He is the director of National Institute of Cardiovascular Diseases. And his topic is complex cases through radial.
Learned faculties from home and abroad, my teacher of teachers, father of cardiology in Bangladesh, National Professor retired Brigadier Malik sir in front of me. Assalamu alaikum. Complex cases through transradial approach. Let us see what is the definition of complex PCI. The term complex PCI is a descriptor applied to patients presenting with complex anatomic coronary lesions. And these lesions are maybe severe calcification, extensive thrombotic burden, extreme tortuosity or length, might be chronically totally occluded. The lesion location might be located at a coronary bifurcation, degenerated saphenous venous grafts. And if we see this picture, there is some adding points, left main lesion, proximal, including proximal, LED lesion, bifurcation lesion involving side branch equal to or more than 2.5 millimeter, lesions requiring rotational atherectomy, lesions more than 30 millimeter length, thrombus containing lesion, lesions requiring more than 3 stents, lesion more than, there are treating more than 3 lesions, and treatment of chronic total occlusion, bifurcation lesion requiring 2 stents. All these are included in different studies as complex PCI. There are some high-risk PCI. These are the complex anatomic situation in addition with hemodynamic compromise like shock or severely depressed LV function, clinical comorbidities such as advanced age, diabetes mellitus, peripheral vascular disease, heart failure, acute coronary syndrome, or previous cardiac surgery. Then what does expert says? Let us see. According to Shaman Sharma, there is usually no clear definition of a complex PCI patient. However, we usually refer to the lesion characteristics to define complexity. Those are as like before, calcific lesions, total occlusions, bifurcation, and of course, the vein grafts. And sometimes the patient with multiple stents can be considered as complex PCI. And if we see what Paul Terestin tells, people often talk about advanced age and renal failure. But for me, it's really about what the lesion looks like on the angiogram. For example, bifurcations, calcified lesions, long lesions, tortuosities, CTOs, unprotected left main. I might add poor left ventricular function there as well. Those are the main criteria, in my view, for a complex patient. And according to another, these they have also tell the almost similar things. And to me, the complex PCI is left main and functionally significant any bifurcation, true total occlusion, lesion which needs plaque modification, calcific venous grafts, multivessel disease, left main, and any functionally significant re-stenosis, ISR. Then till now, defining complex intervention is still a question. Can we do all the procedures through transradial approach? Almost, as because there are some evidences, there is clinical benefit, financial benefit, as well as patient comfort. Let us see only a few cases. My first case, Mr. X, 48 years old, non-diabetic, normotensive, non-smoker, presented with central chest pain for 10 hours. And at first he was presented to a local hospital. There was treated with loading dose as well as low molecular weight heparin. This is the scenario of the ECG, intraseptal myocardial, full-blown myocardial infarction. And echocardiography, left ventricular ejection fraction is 50. And this is the coronary angiographic findings. You see, there is distal left main involving osteum of the LADL6 and trifurcation lesion. And RCA is almost disease-free. And now what can we do? What should be the strategy in the setting of acute coronary syndrome? We crosses the wire both into the LAD and LCX and predilated the lesion. And we have done IVAS from LAD to LM as well as LCX to LM. And we have found that LCX osteum is almost LCX ostia is 4.19 and LAD osteum is 5.08 and LAD mid is 2.81. And so we plan to give a stent from left distal mid LAD to LM involving the 8 millimeter from the confluence of and inflated the stent, and stent deployment is in progress, pulling back the stent balloon and higher inflation, and then post dilatation done. And after post dilatation, and we have done the post dilatation. After post dilatation, we have done once again the IVAS, and we have seen that the LAD osteum is 9.67, LAD proximal 9.08, and 8.56 mid LAD, and MLA distal LAD 6.33. And confluence is also 15.24, and distal LM is proximal LM is 15, and distal LM, which is in stented, that is 14. And this is the final view. And this is the ECG just after the procedure. You see the T has become uprighted from B3 to B4-6. And this is another patient, Mr. X, and he is a patient on maintenance hemodialysis and was waiting for renal transplant. And we have done coronary, he has CCS grade 3, and we did the angiogram, and there was a loop which we have overcome. And this is the scenario of the coronary angiogram. Right coronary artery diffuse the diseases with heavily calcification, and left coronary system is almost normal. And so we have done angioplasty by distal radial approach, and wire is negotiated. And after single wire is negotiation, we could not cross the IVAS wire, IVAS catheter, and so we give another wire, and IVAS pullback was done. And this is the result of the IVAS. You see there is a nodule in the mid LAD, and almost 360-degree calcification is there. So as because this is a dominant RCS, so we have taken a temporary pacemaker support, and we have done rota with 1.5 bar. And after rota 1.5 bar, result is not up to the mark, and so we increase the rota bar to 1.75. And after rota bar, we have done IVL balloon, and you see the IVL balloon is in progress, and you see in the mid panel, the IVL balloon there is also dog boning. And after this IVL balloon, we have done post dilatation with a Scoreflex balloon, and after that we have given 2 stents. One is distally and another is proximally. After giving 2 stents, we have post dilated the proximal lesion with a 4 into 8 the entire lesion, and proximal part 5 into 8 balloon, and this is the final result. As time is going up, so take home message is definition of complex coronary intervention is still evolving, and complex coronary intervention needs heart team approach. Almost all complex coronary intervention can be done by transradial approach, not necessary 100%, as because sometimes we require 8 French guide, which is not feasible by transradial approach. This is my team, and thank you all. Thank you for patience here.
Thank you, Professor Mir Jamaluddin, for your brilliant presentation. Next speaker, Professor Dhiman Bambi, Professor of National Heart Foundation Hospital. He will present the grab vessel PCI.
Respected chairpersons, respected moderators, teachers, colleagues, and friends, and the learned audience from home and abroad. Today, my presentation is on grab vessel PCI. With due respect to the cardiac surgeons, the depth of the problem is recurrent ischemic symptoms appears to in more than 4 to 8% in post-CABG patients annually. Saphenous venous graft is most common causes of 40% during the first year. 1 to 2% of the graft occluded annually 1 to 5 years after surgery. After 10 years, all half of the saphenous venous graft are occluded, and half of the patent saphenous grafts are diseased. With this depth of the problem, I start my lecture. SVG disease occurs in 3 phases: the early phase, intermediate phase, and in the late phase. Early phase occurs before hospital discharge. This is due to the thrombotic closure of the site of the anastomosis. These are due to the poor distal runoff of the vessel, graft kinking, and small target vessel diameter. Intermediate occlusion occurs within months and years, within 1 month to 1 year. Exposure of high arterial pressure in the saphenous venous graft, neointimal hyperplasia, intimal damage, fibrosis, platelet aggregation, the release of the growth factors, and smooth muscle cell proliferation. Later on, beyond the years, 1 year, aggressive atherosclerotic change occurs in the saphenous venous graft due to the abnormal endothelium. Factors which are more chance of getting repeat revascularization after CABG are a female sex, diabetic patient, prior PCI, dialysis patient, and incomplete revascularization. Atherosclerotic plaques in the SVG graft shows diffuse and friable condition, contain foam and inflammatory cell, having absent of a small fibrous cap, and a lack of or no calcification. This is the first case, a hypertensive diabetic patient of 59 years. This is his native vessel, showing all the 3 vessels are occluded, and this is the Lima graft, is patent. The graft to the SVG graft to the PDA is 90 to 95% stenosis, and the graft in the OM is patent. So we decided to do an PCI to the SVG to PDA graft, run through floppy wire, and the distal protection device is advancing. You can see in the second picture, and with the distal protection device, 4 into 2 24 millimeter dilating stent is deployed at 12 to spare, and the last picture you say, and it is the final result. We remove the device, distal protection device, and this is the final result. The decision regarding the whether to intervene in a diseased saphenous venous graft is guided by patient symptom, angiographic evidence of significant stenosis, and non-invasive evidence of myocardial ischemia in the region of the saphenous venous graft supply. PCI to the native vessel is encouraging now times. It should be preferred because of lower complication and restenosis rate before doing an SBG graft. The lesion in the native vessel are rigid and more calcified, and this poorly responds to the balloon angioplasty. And debulking by rotablation is particularly helpful in this size in the native vessel. SBG graft obstruction occurs in about 5 to 10% in SBG graft PCI is 5 to 10% in all PCI, in complex PCI. SBG grafts are difficult to PCI is because it is inadequate dilatation of the SBG graft. There are significant about 20% major advanced clinical events occur as myocardial infarction, no reflow, high rate of restenosis. Compared to the nasal-betal artery, atherosclerotic plaques in the SBG grafts are more diffuse, thinner, and more friable fibrous cap, increase the risk of distal debris embolization. This is another case in a patient with ACS, ACS in a patient with CABG. We can see their OM graft is diseased, and we cross it with a run to floppy where distal protection device is used. And this, after the inflation of the stent, this is the picture. Drug-eluting stents or bare metal stents in the venous graft. This is a randomized trial and a meta-analysis of drug-eluting stent versus bare metal stents, which is published in November 2018. They concluded that drug-eluting stents have been increasingly utilized during percutaneous coronary intervention in saphenous venous graft, without strong evidence of favoring their use. There is no significant difference in mortality, target vessel revascularization, myocardial infarction, or stent thrombosis between drug-eluting stent and bare metal stent in saphenous venous graft PCI. Dual antiplatelet should be given, and it is favored in saphenous venous graft of less than 3 mm in size, and in patients who have high increase of developing restenosis, that is diabetic patient and long segment lesion. This is the latest recommendation of treatment of SBG disease, and it is published in 2022. And this shows us in selective patient with previous CABG undergoing PCI on a saphenous venous graft, the use of an embolic protection device, when technically feasible, is reasonable to decrease the distal embolization. This is a class 2A indication. In patients with previous CABG, if PCI of a diseased native vessel artery is feasible, then reasonable to choose PCI of the native vessel artery over PCI to the diseased saphenous venous graft. This is also a 2A indication. In patients with chronic total occlusion of an SBG graft, the percutaneous intervention should not be performed. It is a contraindication. I am lacking of time, so the complications of the saphenous venous graft PCI has occurs in due to atherosclerotic MI may happen, bleeding, no reflow, or graft vessel perforation. Embolic MI may be prevented by avoidance of the bulky saphenous venous lesions by performing native vessel PCI, easing of an embolic protection in saphenous venous when possible, direct stenting of the vessel, slightly undersize the stent in the saphenous venous graft. Stent deployment should be done slowly and to minimize distal embolization, avoiding post-dilatation in the stent of the SBG. These are the more important points in doing an PCI of a saphenous venous graft. No reflow can be done with the vasodilators given. I strongly acknowledge Professor Fazila Malik and Professor Mir Naseeruddin Ahmed for preparing this case. Take-home messages are distal embolization, no reflow, abrupt closure, perforation, and high degree of elastic recoil of the graft vessel are challenges in graft vessel PCI. Successful recanalization is low, totally occluded saphenous venous graft. Easing of a distal protection device, direct stenting, stent deployment done slowly, and avoidance of a post-dilatation of the saphenous venous graft stents can prevent the complication. Thank you all for patience hearing. Thank
you, Professor Dhiman Monik. Next session is discussion and audience interaction. That is, I like to invite from the audience and from the discussion for questions to Professor Fazlatul Nesha Malik.
Maybe I could kick off. So my name is Keith Oldroyd. I'm from Glasgow in Scotland. So first of all, congratulations on the rigorous timekeeping. That was ferociously strict. But we started early, so we've got some great time for discussion, which is quite unusual in clinical meetings. So maybe if we go back to the beginning to Professor Malik's nice presentation, which focused on the issue of diabetics, obviously a big problem in this part of the world and everywhere, and whether or not, for instance, a novel device with drug coating on the balloon and on the stent struts might produce benefit. Could I maybe ask Professor Malik to come back and deal with any questions, and we'll go through the panel in a second. So first of all, is there any randomized clinical trial evidence that this device is superior or even equivalent to conventional drug-eluting stents?
Well, that is the crux of the matter. You need evidence. And for that, I mean, there have been small registries or multi-center trials, but one of the largest global trials has just been completed. It's the Ability Global Trial, and we were also part of that. And so this is a randomized controlled trial addressing this issue in diabetic patients, and it's been compared with science. So the results will be published.
So this is the study that Roxana Moran is involved
Roxana
in from
Moran
Mount
and
Sinai.
Marie-Claude Maurice,
Yeah.
the two of them conducted this. Yes.
And the recruitment's complete.
The recruitment
Okay,
is
that's great.
3,500 patients were recruited, and the recruitment is complete. So we also are awaiting the results because it should be interesting. And it was like we did with patients with poor ejection fraction, non-STEMI, very diffuse disease.
all
So,
comers.
Yes, all comers.
Okay, that's going to be a very exciting study when it reports, obviously. Maybe I could go to the panel and ask the discussants, do you adopt any particular strategies when you're dealing with diabetics rather than non-diabetics?
I've picked up the microphone, so I can start. Yes, I think there's an increasing reliance upon intravascular imaging to optimize the results. So you showed a beautiful case with very diffuse disease, and we know that diabetic disease often is complex, long segment, maybe small vessel, all with heightened risk of restenosis. So increasingly turning towards OCT or IVUS to guide, as you showed in your case example. If I could answer, but also with a question related to the study, obviously the stent is only one part of the success of the procedure. And in terms of a long-term result, the ongoing therapy for the patient, so glycemic control, other cardiovascular risk factor modification is going to be key. Is that factored into the study design, that aggressive risk factor modification persists?
Well, actually, this is the crux of the matter. For those of us who treat diabetic patients, I mean, putting in a stent is the easy part. Following up these patients, motivating them to control their diabetes, to control other risk factors, to give up smoking, that is the hard part. In this trial, as per se, we have not been asked to, counsel our patients, but we are doing serial HbA1c monitoring. And obviously, when we are seeing that our patients have their HbA1c not up to the mark, we are giving them advice. We are trying to adjust their drugs as well. But it wasn't a part of the trial.
Can I ask you a question?
Yes, please.
The thing is, nowadays, in treating diabetes, the SGLT2 inhibitors, these drugs have shown effect in multiple organs. And so the hepatologists are claiming it's our drug. We, the cardiologists, are adopting it like anything. The nephrologists are also saying it's good for us. And also some have shown there is a cognitive improvement with use of these drugs. is there any study or any hypothesis regarding the vigorous use of these drugs, SGLT2 inhibitors, in the restenosis rate and other things?
In the restenosis rate, I'm not aware of that. If anyone is, they can say, but
Well, it's a great question, and of course, at the recent ESC meeting, for instance, there were several studies in heart failure with reduced ejection fraction, preserved ejection fraction, combination of the two. Actually, I'm not sure that anybody understands how SGLT inhibitors actually work, but it's a great question whether they modify the biology of atherosclerotic plaques. And I'm sure there's a lot of research going on this at the moment. Yeah. Any other questions for Professor Malik on the first presentation?
Yes, I want to put a question, but before that, I just want to acknowledge that all the 4 presentations were just brilliant, and we all learned a lot from the presentations. I have a little question to Professor Fazila Malik Madam. That in your case, you showed that the LED was treated with drug-eluting stent and diagonal was treated with drug-eluting balloon.
yes.
And what would be your strategy if there was dissection in the ostial diagonal? How much dissection would you have, allowed to treat conservatively? Number 1. Number 2 is there is not much, evidence of using drug-eluting balloon in acute MI setting. Can you comment something on that?
Thank you. That's a great question. And actually, if you can allow dissection up to type B, now that is what is allowed. And there should be definitely TE3 flow. If your dissection is flow limiting, then you should just go ahead and put a second stent there. If you think that vessel warrants to be kept open and you cannot afford to lose that vessel, and there is flow limiting there, then put in a second stent. That is what I think is, but they are more experienced than I am. I mean, Tom showed some great cases yesterday. So maybe you would like to comment on that, Tom. And about MI also, you were saying that this is a great idea for MI also, maybe in a very heavy thrombus load, what you do thrombosuction and then just do DCB. Would that be viable?
I think in answer to the...
So he's got 2 questions. One is what kind of dissection you allow. So it's type B and it should not be flow limiting. That's the answer, I suppose.
Yes, as we discussed yesterday, I think the existing classification for dissection is actually quite distracting and not very helpful for the purpose of using drug-coated balloons effectively. So the A to F criteria are actually very difficult to apply when you're wanting to achieve a stent-free result. So the consensus has very much shifted towards the consideration of a vessel-threatening dissection rather than maybe AB versus C to F. And I think there's still quite a steep learning curve in terms of really understanding what is vessel-threatening and what's not. And actually the classification is very much historical and comes from a POBA era where potentially the pharmacology also was against us. So now with more potent P2Y12 inhibition, I think actually the risk of vessel closure is probably much smaller than we first thought. So I personally believe that imaging again is going to play an important role there, but for the moment it's being avoided because if anything it complicates decision making. But I think there's a lot to learn. It's a very exciting space because there's huge amounts for us to learn and develop, I think, in doing that safely.
I mean, one of the interesting things technically is that you can usually do prolonged balloon inflations in side branches without inducing substantial ischemia, and you would certainly have been able to do it in your case because there was good collateral protection. So, of course, many younger interventional cardiologists, I count myself amongst one of the older ones now, many younger interventional cardiologists have never really done balloon angioplasty as a standalone treatment. So as Tom said, there is quite a steep learning curve if you start trying to do stent-free intervention, either in main vessels or indeed in side branches or bifurcations. Yes, question in front row here.
Regarding his question, I like to add whether there is any role of pressure wire to use to see this significant dissection. Dissection is significant. Will require another stent or not? Is there any role of pressure wire?
Yeah, but actually we saw a load of cases by Professor Antonio Colombo
Yes, Colombo
yesterday,
told that-
and he's a great, he really does promote this idea that when he does a he wants to do a DCP after pre-dilatation, and that is one of the crux of the matter. You have to relearn to be gentle, to do a very gentle pre-dilatation, but an effective pre-dilatation. And after that, he does use a pressure wire, and if it is like it's
More than
above
10.
0.9
Yes.
and it is stable, he waits for at least 5 minutes to see that it is stable. Because if it's fluctuating, going to 8 and then coming back to 9, no. But if it's stable, then he goes with his DCB. At least that's what he showed us.
Audience, here is an announcement. As you can see, there is a prize for the best question. So I'm requesting
all the young guys to
audience
come up and ask. So
yes, please do interact and win the prize.
Yes, please. All the young fellows, please ask any question. We don't mind if they're okay.
And requesting our chairperson and discussor, please select the best question.
Good morning.
And you are the judges also.
I'm working here as a registered cardiology. My question is to Mir Jamal sir, that before going to for the complex PCI, is it necessary for us to go for the heart team approach, or we will just go with the scoring and just go for the complex PCI? And next question is that for complex PCI, the route of choice, in which route we will go for? What is the recommendation, or is there any choice there, whether we can go for the radial or femoral one?
Thank you for your two excellent and time-worthy question. Regarding the answer of your first question regarding heart team approach, yes, we need, but not for all cases. As for example, a CTO, you need that revascularization is essential, and for doing a CTO, I do not think that a heart team is approach. But some of as because I have shown that still there is dilemma for the definition of this complex PCI, though they have different authorities has given the different definitions. Even then, we have obtained many of the points in favor of complex PCI. So almost all the complex PCI does not require heart team approach. And second one is the route. Route is not the matter, though I am a radialist. I want a result. I want the performance. But almost all the complex PCI up to using 7 French guide to me is possible. And if I require 8 French, then I surrender. Then I go to the femoral route. Or in acute crisis, very recently I have done one case, only 7 French guide I negotiated, but I could not do, and I had to go by femoral route. Patient was in shock, and that is why I have gone to femoral route. So answer is that we should have to obey the lesion, we should obey the patient, we want the adequate result, and whatever may be the route, preferably nowadays all over the world, you know, in UK it is approximately 90%, in Europe approximately 70%, but we are a bit lag behind. So we should try to go to radial route. Thank you.
Thank you, sir.
Could I extend that question? You showed an example of using the distal transradial approach. When do you select using a distal transradial?
Yes, thank you. Since starting 2017, 3rd December, I have seen here, Dr. Patel came and he shown one case. Since then, I have started distal radial approach, and more than 6,000 cases we have done in my team in distal radial approach. And now my default technique is distal radial approach. Whenever I fail to the distal approach, then I go to the radial approach, and whenever I fail the radial approach, then I go to the femoral approach. For selecting, no matters, as because the distal radial approach may accommodate 7 French guide, 6 in 7, that is glide sheath slender. So to allow 7 French guide by the distal radial approach is easy. But for some cases like female patients, short stature, very elderly, I try to avoid the distal radial approach, and very long person, very tall person, I usually avoid as because the length of the catheter sometimes becomes short.
Thank
Question
you.
in the audience?
I'm Dr. Noor Alam from NICVD. I have a question to Professor Hafiz Ahsan regarding myocardial viability.
Okay, good.
In
So-
CTO
So this was a very rapid. Come back to the podium. He went through his slides very, very quickly. So it's good that we have some time to spend. So you go ahead with a question.
in CTO lesion, when there is a very good retrograde flow, should we go for viability testing or only we depend on the symptom of the patient for CTO opening?
Yeah, I think symptom is one thing, but we want to be convinced that there is a large area of ischemia at stake, because CTO, whatever we claim, is not a benign procedure. So before we embark on a CTO, we need to make sure that there is an indication to go for the CTO. So
let's just set the scene here for a second, because you didn't really have time to go through the revived study. So the revived study, as some of you will know, and you did mention that there was a sigh in the room in Barcelona when it was presented. I was in the room, and it's true. The audience groaned loudly when they saw the result. So we took part in this study. The study required patients not just to have poor left ventricular function and complex coronary disease, but they also had to have viability. And we recruited 80 patients out of those 900, and they all had cardiac MRI scans to assess viability. And despite tremendous efforts in the PCI arm to do complete revascularization with multiple CTO procedures, the trial was completely negative for its primary endpoint and for left ventricular function. And in fact, last week, the principal investigator from King's College, Devaka Pereira, came up to Glasgow to my own hospital and presented another analysis of the trial looking at the incidence of sudden cardiac death. And it was also completely identical in both arms. So this is a very, very important study. Now, one thing you have to remember, when you do a randomized trial, you're looking at the average result at the end of the study for the patients in each group. Of course, when you take patients individually, there may still be some value in some patients of viability testing and of revascularization. The trick is trying to find the patients who benefit. So maybe you could expand a little bit on your thoughts about viability, and then we ask the audience in the panel what they think about the results of Revived.
I mean, we don't quote anecdotes in medicine, but anecdotes help. We have a lot of experience individually in this room that you have seen this. LV bad, and then you go with the PCI and the LV gets better. But the question is it after the Revive 2? The whole question of viability is dead or not. But let me answer that question in the CTO. CTO in the context of symptoms, ischemia, and the LV function, and then the risk. So, we talk about the complex patient, complex lesions, but complexity is our problem. Complexity for the patient is a different thing, right? Complex lesion. We talk about, bifurcating lesion, calcification of delivery of the devices. That's really our problem. The patient wants to see a good outcome. So if you want to do a CTO, I would request you to look into these aspects as well. Now, for the Revive 2 is a specific question about the LV dysfunction, and then revascularization will help or not. So it raises the question that what about our historic data on the cabbage trials? We did cabbage and LV got better. We know that. What went wrong with the viability guided PCI then? So some are saying that question is answered. And I'm trying to tell that this is probably not over yet. Maybe in this group, we need to tease out, hibernating myocardium, viability, but who in that group may show benefit in terms of having the underlying contractile reserve? Because ultimately that has to be seen, that the contractile reserve comes back. So Dr. Narula mentioned a couple of things yesterday. Let me give the analogy. The FAME2, then the physiologic assessment, plaque morphology, plaque physiology. Another important factor, he has published this plaque, high-risk plaque, and the prediction of this, how plaques will progress. And those which have a potential to progress, and they can bring troubles in the medical group if you leave it alone. So if you think that way, the LV dysfunction with a huge area of ischemia and there is potential for recovery, maybe those patients may benefit. I don't know.
Hafiz Bhai, my question is, we have been paying too much attention to the physics, to the hemodynamics of the patient, trying to improve them. And should we be paying more attention to the biological side, like cellular growth and the other factors? Because these new drugs that are coming up, like vericiguat or SGLT2 inhibitors, they act on the cellular level and giving us very good results. Do you think that will be the future?
So I gave you my last patient where actually I restrained myself and did not do anything because I wanted to see that the maximum medical therapy will improve. Because if the LV function improves by maximum medical therapy, that is a proof that there was. It's like love. If it comes back, it was yours. But if it never does not, it never was. So I don't know.
And can you explain? Sometimes we get patients who have 25 or 30% ejection fraction, but they are doing very well and totally asymptomatic. And again, we got patients with around 40% ejection fraction coming to us with repeated episodes of heart failure.
Absolutely.
And, do you think these are the groups, the later group, who needs intervention? The previous group do not?
Yeah, but if you look at you are here, the Revive 2 study design, they have done everything possible. So you can't just say that this was. Any comment?
So we also participated in Revived. I think there are two elements that come from this. So the question initially about CTO, I'm not a CTO operator, but it's interesting to see how that has evolved in terms of the excitement initially of doing highly complex procedures and now limited really to the patients who are very significantly symptomatic. And there is undoubtedly a benefit in terms of undertaking CTO for the purpose of alleviating symptoms. You mentioned at the beginning of your presentation that we do the intervention for one of three reasons: symptoms, and then ultimately survival being the kind of major outcome that we're wanting to overcome. And what Revive shows us is that actually survival is very poor, regardless of medical therapy or revas. So 40% mortality in this cohort of very high-risk patients. And so undoubtedly there's more that we are going to need to do. This issue about vulnerable lesions and whether stents are really the solution for kind of overcoming vulnerability, I find really difficult to kind of grapple with. So it's more likely it's going to be medical treatment and maybe bypass surgery for patients with very high risk, high burden disease is a solution. We have to consider that.
So any questions from the audience? Because if we're having our
I just
prize,
want to make one comment.
we only have 2 questions so far to choose from. So we need more questions.
Do you think that the mode of measuring viability matters? As for example, if you take a PET scan, then it will show that there is viability if there is a few cells are viable.
But if you take another stool, as for example, dobutamine stress, it will show viability when a majority of the cells are viable. So if you depend on the tool of viability, as for example, PET scan or MRI, which shows us very small cells which are viable, you do not know how much is viable, then you go for a PCI and see the results are same. And if you see that you do a dobutamine stress and a large area of viability is there and you do angioplasty, the results are better. Can these two modes differ?
In the world of viability, it sometimes becomes like a religion, which one you believe in. If you talk about Dr. Bono with the contractile reserve and dobutamine stress echo versus PET versus, but I can tell you this, if you do one mode with comparing to others, these are not bad. Thallium may have less sensitivity and PET may have more sensitivity, but to resolve that issue, some propose like combining multiple modalities of viability. But the Revive too, to be fair, they did everything and in terms of proving that there is viability, and that's why they went after. I want to make one comment though, and this is the reason we actually do this conference. We need to know the data and knowledge even more than we do need in Western countries and developed countries, because these issues, it involves cost. So we should not be instituting this kind of devices and procedures and do this here unless we are sure that it does have a tangible good outcome.
That is a very, very important point. If you spend a lot of resources on low value care, the outcomes for the community are not going to be good. And I mean, Revived has moved us forward. I mean, it may be a disappointing result for doctors who want to do complex PCI in patients with bad LV function, but it's certainly moved the discussion forward.
How about remember acute coronary syndrome? That is a different ballgame. So yeah. I want to
make these were stable patients. This is stable coronary disease we're talking about. Yeah. Question here.
I have two questions. So the first regarding the stitch and like viability, they used SPECT and they used thallium, and they combined the dobutamine and the nuclear assessment. Do you believe like this is one of the major limitations for the study? Maybe in the future we use more like the newer agents, and even the protocol when they did with the stitch, they give the 1 day imaging. They did not re-image again. I didn't use nitro with the SPECT. So
the guy who is sitting next to you is the guru of viability testing also. So maybe Dr. Narula can answer that.
So I think when we really talk about viability, I think it's a very difficult subject, and I don't think we really, and whether even Revive gave us that kind of an answer. The problem is that anything which is not scarred is viable, right? Whether it will result in a improvement in contractility or not, whether it is going to improve the survival or not, that's a very difficult question. Reason is that the viable myocardium could be a stunned myocardium, it could be a hibernating myocardium, it could be a remodeled myocardium, right? So remodeled myocardium is a myocardium which basically has just altered, right? And its contractility has reduced, but nothing that you do to it for a foreseeable future, it is not going to improve its function. Now, our follow-ups in most of these studies, they have not been enough for us to see the reverse remodeling effect. And that is the reason that this pitch trial might start changing its result from 2 years to 5 years to 10 years, right? Then you talk about the hibernating myocardium, which becomes the next one, where there is a resting ischemia. How is that going to improve? And the third one is where there is a repetitive stunning of the myocardium because the patient has got significant stenosis in multiple vessels. The person walks from, say, 10 steps and develops ischemia. That ischemia causes some damage to its contractile proteins every single time. Right? And that myocardium gets repetitively stunned. And that will have a very different outcome when you will revascularize them. And I was giving you the anecdote of my own dad who had a triple. CTO of right coronary, CTO left anterior descending, 90% pre-OM1 lesion, huge circumflex, which was literally supplying the whole myocardium, 23% ejection fraction, had a 7-vessel bypass in Houston, lived 16 years thereafter without a single tablet of nitroglycerin ever needed, with ejection fraction of 65%. That is what the hibernating myocardium was. And if I had done the viability, PET would be positive. But then again, I will have to tease it further and would have to say that it was either truly a hibernating myocardium or it was truly a repetitively stunned myocardium. So if we go to that extent, yes, we will be able to identify the mechanisms there. Currently, what we do is quick and dirty test. When you do an MR and tell me that the entire thickness of the myocardium is gone, obviously you know it is all a scar, right? And then when we do the contractile reserve, again it is a very crude test of telling you whether the ejection fraction is going to improve or not.
Thank
Okay,
you.
that's
Thank
great.
you all. We are running short of time, so I'm requesting judges to please conclude this session and declare the winner name or the question. Who wins the prize for best
any
question?
last questions? We have 2 minutes left. Any last questions from the audience? One more.
Sorry, actually, I have a question to Professor Fazila Malik, madam. Actually, you always have to work in a limited resource setting. So one experience I can share with you. We have used one drug-coated balloon for a long lesion in the LED distally. It was around 30 millimeter length, but the proximally there was lesion. So we have inflated the balloon distally and the patients cannot afford. So we have again inflated the balloon proximally. So can it be done twice?
A drug-eluting balloon.
Drug-eluting balloon, can it be
You
used
want to
twice?
answer?
Suppose we can use it distally, then we again use it proximally. All the drugs are liberated in the just one time.
It depends how long you've left the balloon in contact with the vessel wall. So if you've done, I mean, strictly speaking, if you listen to the manufacturers, the instructions for use, if you do a 30 to 45 second inflation with a drug-eluting balloon, and you want to treat another segment, you need another drug-eluting balloon.
Absolutely, yes, you do. That's
you.
the honest answer. I mean, even like you have to go very quickly because you don't want to, the drug, you're losing it, right? So that's why once you've inflated it for 45 seconds, there shouldn't be any residual drug left there. So you need to use another.
Yeah, madam.
drug.
One time it happened. We have opened the drug-coated balloon. We couldn't negotiate through the lesion because the lesion was not adequately prepared. So
Okay.
again, we have made the stand out. Then again, we have put, and we are in actually doubt. Actually, does this drug-eluting balloon works or not?
Absolutely. So that is another crux of the matter. We have to prepare our lesion very well so that we don't waste time. And if you suspect like that, you use whatever tool you have to prepare your lesion. Otherwise, the drug gets
Right.
wasted.
Thank you, madam.
Yeah. Okay, great question. Yeah. Okay, so fantastic. It was great that we had a good 30 minutes for discussion there. It's a great discussion, lots of good questions. So I think we're going to close this session now. I think it's tea now for 20 minutes, and we'll reconvene at 10:50 for the next session, which will be an exciting live case from the cath lab
Right.
here.
So someone has, Tom, have you decided on the best question? Have you were this side? They were asked to think about it. So did the four of you think about and choose a winner?
So I would have to say that the first question that was asked, really asking about
Shamin,
the
Dr.
importance,
Shamin Chaudhary.
the importance of heart team, I think is an essential element
Shamin
to
Chaudhary,
consider
please
in
come
complex
forward.
intervention.
He is the registrar of our hospital. And this prize is sponsored by Aristo Pharma.
So, please take a all
Judges,
of
please
you-
come forward and hand over the prize.
So this is done to encourage our young people to think. Please go ahead and take a photo with him. Yes, thank you.
Audience, let's have a tea break now. Our next session will be a live case which will be telecasted from our cath lab and which will start by sharp 10:55 a.m. So hope we will assemble back on time. And requesting all our speakers, chairperson and judges, please let's go to our photo booth and hand over the memento to our speakers and have a group photo. Please let's go to the photo booth and hand over the memento to our speakers and let's have a group photo, please.
Memories and encouragement.